Welcome to ATCM, the Emergency Medicine channel. Today we will be discussing about a case of an elderly male who presented to our ER with complaints of breathlessness since the last 1 week. So 62-year-old male patient was brought to ER with complaints of breathlessness since last 1 week. Initial 10-second assessment, patient was conscious, oriented and obeying commands and was brought in NIV. So his airway was patent, there was no pooling of secretion, hoarseness or gurgling. Breathing, his respiratory rate was 46 per minute and saturation was 92% with 80% of FiO2. Circulation, his heart rate was 152 per minute and blood pressure was 112/68 with a map of 82. Disability, his GCS was...
So you can just say what mode of BP measurement was being done.
It was manual BP was checked. Disability, his GCS was E4, V5, M6 with pupils of 2 mm bilaterally equally reactive to light. And exposure, his temperature was 99 degree Fahrenheit and GRBS was 152 milligram per deciliter. Adjuncts to primary survey, his airway was patent, breathing, he had labored breathing and he had hypoxia. So he was continued.
So already assessed the airway in this patient, he was already on a NIV, no?
Yes. Airway wise, there was no pooling of secretions or gurgling or anything, obviously. Okay. And he was sensorium was also full, sir. So he was able to maintain his airway.
Okay.
NIV was continued and we increased the FiO2 to 100% and he was able to maintain a saturation of 95% after that. 2 large bore IV cannulas were inserted and cardiac monitors were connected and we took an ABG. ABG was showing a pH of 7.297, PCO2 of 49.5, PO2 of 95.1 and a SO2 of 96.4 and bicarbonate of 23.5 and lactate of 2.8. So it is a acute respiratory acidosis is there and PaO2 by FiO2 ratio is coming as 95.
Now you have a patient who is having a respiratory rate of
46
and still the PCO2 is slightly on the higher side, no? What does it indicate?
All the alveoli might not be participating in the oxygenation process. Okay. Or patient is going for a failure, later failure.
Does he have any other pre-existing illness like COPD?
No, nothing. Cardiac monitors were connected and 12 lead ECG was taken. ECG was showing a AF with fast ventricular rate with a heart rate of 154 was there, sir. It was treated with 5 milligrams of Metalar and it reverted to normal sinus rhythm. Since he had a temperature of 99, we have given him Tab-Dolo was also given.
So with Metoprolol, the rhythm reverted or rate settled?
Both.
Is it possible to settle both in a single dose of Metoprolol?
Rate will get controlled.
Rate will definitely, most of the time it will get controlled. Rhythm, is it possible by Metoprolol? Theoretically, it is not. Very rarely you get such response.
What are the drugs which will control the rhythm in air?
Amiodarone will be controlling the rhythm.
Okay, continue.
Sample history, patient, no comorbidities was there. Patient was not taking any medicines. Last meal was 6 hours back. Patient complains of fever since the last 8 days associated with breathlessness. So initially it was NIH grade 2 only and with that breathlessness he was doing his he was going for work and all, but gradually his breathlessness worsened and since the last 4 days he has reduced urine output and he was taken to outside hospital and there he was started on oxygen and NIV and all and there they found his counts to be elevated and he had
what was the rhythm and rate, anything documented?
No documents were there, sir. and they found him to be having an elevated creatinine of 7, and desaturation was also there. So they started him on NIV and shifted here for further management. There was
So
no
what are the differential diagnoses you can think now with this available history?
It can be bilateral fever history is there, fever breathlessness history is there. It can be pneumonia can be there.
Bilateral pneumonia due to
Viral,
viral pneumonia. Okay.
Then we have a report of a high elevated creatinine value.
Okay.
It can be a nephrogenic pulmonary edema. Can be a
uremic lung. It's something like ARDS, or you can get nephrogenic pulmonary edema. Both are possible in a renal failure. If the patient is having good urine output, uremic lung can be there. There is less urine output, it can be pulmonary edema. What we are discussing, like some fluid overload condition.
Then elderly, this is an elderly man, so there can be a cardiac failure also. Cardiogenic pulmonary edema can be there.
So all are possibilities. ARDS.
ARDS is also possibility. There is an acute onset of breathlessness since the last 1 week. Is there, and the PaO to FiO2 ratio is reduced. And we also have a chest X-ray from outside which is showing bilateral infiltrates.
Diffuse infiltrates. Any other non-infective conditions can present like this? Bilateral infiltrates in chest X-ray. Infiltration of malignancy throughout the lung field is possible then.
This thing, chemical pneumonia.
Inhalation of chemical substances then.
Lepto and all.
Alveolar hemorrhage, another possibility then.
In vasculitis and good pasture syndrome.
Okay, there also you can get infiltrates. Any other things which is very common? It's not very common, which is
drug-induced pneumonitis.
Drug. Eosinophilic pneumonia is one of the common presentation is bilateral infiltrates like this. It is not very common in our area, but it can be there. You can get some cases. That's a non-infectious condition. Okay.
Other thing in Western literature now is E-Valley, e-cigarette and vaping induced lung injuries.
Any other infiltrates like that, non-infectious infiltrates, like eosinophil infiltrates? They can have lymph nodes. Sarcoidosis. So when you are seeing an X-ray alone, you can tell all the differential diagnosis. But when we have a clinical history, the differential diagnosis will come to a narrow list.
Also remember Trally also.
So on reassessment, a patient was on NIV mode and his respiratory rate was still 50 per minute, but he was maintaining a saturation of 95% with 100%.
Is that NIV failure or is still holding on?
Patient is still holding on, but he is not improving with NIV, sir. Okay. There is no, he is not getting better.
His basic problem is not improving. Only saturation alone is improving.
So once you say NIV, what are the other settings involved?
NIV, he was kept on, pressures were kept as 14 and PEEP was kept around 8, sir.
Okay.
And FiO2 was kept as 100%.
Any specific mode in NIV?
No, sir. It was kept as a BiPAP mode itself. Head to foot examination, there was no any peculiar features in head to foot examination. There was no pallidictus, clubbing cyanosis, lymphadenopathy or edema. A respiratory system examination, upper respiratory tract was appearing normal. Lower respiratory tract, he was using his axillary muscles of respiration. Trachea appeared central, and there was bilateral fine crepitations, bilateral diffuse crepitations were seen. So there was no V's. Other system examination was done, and cardiovascular system examination S1, S2 was normal. There was
want to do any adjuncts here?
Yes, sir. We wanted to do a bedside ultrasound was done, sir.
Ultrasound or echo? Which is?
Echo, both should be done,
okay,
sir.
Okay.
So bedside ultrasound was showing bilateral B lines were there, sir, okay. And there was no effusion. Then in the when we did an echo was showing good LV function. There was no LA clots or anything. He had an AF, but there was no clots or anything.
So what do you make out of it? From a diagnostic perspective, you have a normal normal heart with B lines?
Maybe because of pneumonia or because of ARDS. It can be
Non-suggestive of ARDS.
non-cardiogenic
Renal
causes.
failure is also there. You
Yes.
can have fluid overload
Fluid
due to that.
overload. And his IVC was 2 centimeter dilated.
That means fluid overload.
Fluid overload.
You want to say something more about B lines?
Yes, sir. B lines are usually seen in case of overload, sir. In case of ARDS and all, there will be increased vascular permeability and all. So that will be seen as in the field, intercostal fields, and it will be like if there is more than 3 seen at a time, or if we are seeing more than 10 B lines in one lung field, it is
It's vertical lines, right?
vertical lines.
Okay.
So after 1 hour, we repeated an ABG. It was showing a pH of 7.256 with a PCO2 of 48.3, bicarbonate of 20.8, lactate of 3.1, and PO2 and FO2 was remaining normally. But the respiratory, there was a respiratory with the metabolic acidosis in the second.
What may be the reason for metabolic acidosis here?
Maybe because of anyway that time he was not in hypotension or anything, so maybe because of use of excessive use.
Renal failure. Renal failure is already set in. So that itself can produce acidosis. Muscle can produce acidosis.
Lactate was also elevated.
Lactate is how much?
3.
3.
It may not produce this much acidosis. Renal failure is one of the cause.
So HACCOR score was checked at that time, sir. It was coming around 13, sir. So there was no improvement even after keeping NIV. So we planned for an intubation, sir. RSA was planned, sir. So he was.
Why don't you try Lasix in this patient?
Lasix infusion.
No, why didn't you try?
Actually, we tried, sir. We can try, sir.
That has to be tried. We don't know whether it is fluid overload. Anyway, urine output is less, but still we can try it.
So rapid sequence intubation was done with an 8.5 size CT tube with an angle of mouth secured at 22. Drugs used were etomidate and rocuronium, sir.
So here the patient is already on 100% FiO2 on an NIV. What are the special precautions you are going to take while intubating? And what are the risks you are anticipating?
So whenever we are disconnecting from the BiPAP machine, there is a high risk of loss of that PEEP action.
When are you going to disconnect?
Ideally after giving a induction agent just before paralysis, we have to disconnect.
So how are you going to pre-oxygenate the patient?
Pre-oxygenation with the NIV itself, we have to pre-oxygenate, and then after that we have to give the induction agent, fentanyl and etomidate should be given. Then after that we will have to start ambuing.
Ideally you need not even ambu, right? You can do the pre-oxygenation part with the NIV with the head and elevation, and then go for direct intubation. Okay.
Then Foley's catheterization was done and output monitoring was also done, sir. And he was kept on a pressure control mode with the pressures of 30, PEEP of 10, respiratory rate, since his baseline respiratory rate was coming around 45, it was set as 35, and FiO2 was kept as 100%, and he was achieving a tidal volume of 270.
Before coming to that, any other measures you can do at that point to prevent hypoxemia in such patients? What is apneic ventilation? So basically, once you are planning to intubate a patient, you can always have a high flow oxygen or an oxygen running, even when the patient is not actively breathing. Okay, so that you prevent hypoxemia. Second thing is that make sure that hemodynamic stability is maintained all throughout the process of it. Because these kind of patients with minimal hypoxemia itself, they will go into that vicious cycle of hypotension, then cardiac arrest, bradycardia kind of scenario. Okay, so few things to remember. One, if there is an option for apneic oxygenation, definitely go for that. Maximum pre-oxygenation with the NIV itself, minimal interruptions, expert intubator, and also inotropes and other hemodynamic support to be always ready in the back. Okay. So initial ventilatory settings, any concerns you have?
We are in this patient, according to the history and outside X-rays available, it was the ARDS case. So we were targeting a low tidal volume.
How low?
6 ml per kg of the predicted body weight, sir. So this patient, the predicted body weight was coming around 60. His height was 168 centimeters. So predicted body weight was coming around 64.5, and so the tidal volume 6 ml per kg. When we are calculating, it is coming around 387. Sir.
We are keeping low tidal volume in ARDS.
Low tidal volume is basically a lung protective ventilation, sir. So when if we are targeting for a high tidal volume, that can affect the normal lungs and that can cause trauma, barotrauma to the normal.
We are in a normal patient, when we are keeping tidal volume like this, it will not produce barotrauma. Why in this patient? Or in pneumonia also, even if we keep the tidal volume normal level, it will not produce barotrauma. Why in ARDS?
The normal lungs will be affected.
What is happening to the alveoli?
Collapse.
In any other condition, alveoli is empty, or alveoli contains only the physiological things. Here, what it contains some material. Part of the alveoli is taken up by this material. If you try to keep high tidal volume or a normal tidal volume, then that will become an over pressure on the alveoli and it can break. But in a patient who is having ARDS, when we are keeping half tidal volume or low tidal volume, it slowly expands that alveoli which is collapsed or which contains a lot of material, slowly expands. So it takes some time, then we can increase the tidal volume according to the patient's improvement.
Then the PEEP was kept as 10, sir. So we targeted for a high PEEP, low FiO2, but this patient ideally required higher FiO2. So FiO2 was kept around 100 and PEEP was kept as 10, sir.
Okay.
Then
how did you choose the initial PEEP?
Initial PEEP, in NAV itself, he required 8 as a PEEP, sir. So after we kept the same PEEP, but he was not getting well oxygenated. So.
No, you can just for justification, you can say always ARDS net protocol. According to that, you are going to set the initial PEEP. Okay. There are different ways of calculating the PEEP as you go on. We will discuss.
Then we have planned on a fluid restriction and we have started him on Lactic infusion, sir. So but he was not having any output. He was in anuria only. Even after the presentation and starting Lactic infusion, he had only less than 10 ml of urine output, sir. So we were planning on a dialysis for this patient. Then we took 2 blood cultures were taken and we started him on antibiotics. He was started on meropenem and azithromycin.
What is the role of meropenem with azithromycin? Why do you select that type of antibiotic? Why only meropenem? No. Why you are giving 2 antibiotics with the
atypical cover?
Meropenem will not cover.
Meropenem will also.
Coverage is less. Typical coverage for meropenem is less comparing to azithromycin or levofloxacin. It is very less. So you think a typical pneumonia also in this patient? Why did you think like that?
Because a patient presenting with bilateral infiltrates and acute onset of fever, breathlessness.
Acute onset of fever is not a feature of atypical pneumonia. Very low fever, slow progression, bilateral infiltrates, that much clinical symptoms may not be there. Patient can have altered behavior, diarrhea, hyponatremia. Then you think about atypical pneumonia. Here, nothing to think about atypical pneumonia in this case, clinically. But when you investigate, you may get it. Clinically, it is not atypical pneumonia. Clinically, it has to be viral pneumonia. But the only problem is why some other diagnosis you have to keep in mind. Clinically, if you see the lung, it is a viral infection, but some other possibility is there. Renal failure. Renal failure is not very common in viral pneumonia except hantavirus. Hantavirus, it is common. Renal associated renal, liver, everything can be there. Otherwise, renal failure initially cannot present like this. Okay, leptospirosis.
Yes, sir.
It's another differential diagnosis. Okay. Basically, we are treating ARDS, but leptospiro also should be kept in mind.
Following that, we after 1 hour we repeated a blood gas which was showing a ABG was showing a pH of 6.906 and a PCO2 of 83 and bicarbonate of 15.7.
What is the initial rate we have set?
35, sir.
Respiratory rate of 35.
But that time he was not achieving the tidal volume. It was achieving only as 270. That range was achieved, sir. And his lactate was also coming elevating. So lactate was coming around 7, but the blood pressure was within normal limits that time. So we've
Why lactate is elevated here? This patient is having fluid overload condition.
He's in sepsis, so there can be
Tissue
hypoxia. Okay. Tissue hypoxia can be due to the toxins or problem in the tissue, like toxicity producing mitochondrial damage.
Respiratory rate was increased, and we have increased the pressures also to 42. Even after increasing the pressures, we were monitoring the PEEP plateau. We targeted a PEEP plateau less than 30. So that was done, and then after that, he was maintaining a tidal volume, and his ventilator parameters actually improved.
So you still think that it's ARDS? During how many hours the patient's ABG is improved?
Initially,
Within how many hours did the improvement happen? That's the question.
no, the pH didn't improve actually.
That's
sir.
okay. Because some other reason is that metabolic acidosis that has to be improved.
Yes.
Was the patient taken for dialysis?
Yes.
Okay.
That improvement actually occurred within 2 hours, sir.
So you think that still it is ARDS, or you want to keep the diagnosed ARDS live, or you want to keep some other diagnosis here there?
Sepsis induced AK and renal failure causing this thing.
It's called as uremic lung. It's something like ARDS only. That uremia has produced some damage to the alveoli, and that something like ARDS only. But they recover very fast with your NIV or ventilation and dialysis. Patient improves very fast. But if it is ARDS, it will not improve in 2 hours. It takes some time.
A few concerns with the initial ventilatory settings. So if you are setting a rate of like 35, yes, definitely in a patient who is tachypneic and all, it's justifiable to go for a higher rate. But once you are setting in 35, what's the inspiratory time?
Very less.
So always
oxygenation.
Yeah, oxygenation will take a hit, no? So always initial setting you can always put it somewhere close to 24 to 28 to start with, so that your inspiratory time is not compromised that much. And then you can try to increase the pressures itself rather than playing around with that rate. Okay, so what's a single parameter if you are looking at what's it which you want to increase? That's your minute ventilation.
Yes, sir.
Okay, how will you calculate the minute ventilation?
Respiratory rate into tidal volume, sir.
Okay, so you aim at the other end, tidal volume, try to increase the tidal volume rather than the respiratory rate. Okay, then what happened?
Then
Was paralytics used for this patient?
Yes, sir.
Okay.
He was started on a tracheurim infusion was started, sir, with along with midazolam, midasmorphine infusion.
Is a tracheurim needed for all ventilating all such patients?
Actually,
how does it help?
A tracheurim in case of ventilator dysynchrony and all, to avoid that, to take over the patient's respiratory setting, we can give paralytics, sir. But ideally, it should be used less than 48 hours. Otherwise, that can cause critical illness, neuropathy, and all. And
when will you suspect critical illness, neuropathy? What clinical findings will tell you that patient develops critical illness?
Foot drop can be there, sir.
Once you remove paralytics, if the patient develops foot drop, that will be the earliest sign, because other signs we will not be testing every day. Foot drop is one of the important signs.
Then we, instead of using a continuous infusion of neuromuscular blocking agents, we will have to ideally use as a bolus doses. And if at all the patient is improving, that means if we are able to bring down the PEEP less than 8, and if the FiO2 requirement is becoming less than 50, then we can give a sedation gap. The sedation gap can be done, and we can reassess the patient.
Go for a SBT trial.
Yes.
Okay.
Spontaneous breathing trial can be given. This patient was dialyzed, and during dialysis also the patient was not going to hypertension, but serial ABG was showing worsening of lactates. So we have started him on dobutamine infusion, and
How do it help in lactic acidosis?
it can cause peripheral vasodilatation and improve the
Peripheral vasodilatation will not improve lactic acidosis.
myocardial.
Peripheral means skin.
No. Organ perfusion.
Organ perfusion improves. But what is the problem of in this patient? Why the patient developed lactic acidosis? Why the patient developed lactic acidosis? It's not due to the perfusion. Perfusion is happening. It is because of the toxin or hypoxemia which is present in the blood. Blood is going everywhere, but tissue is not getting oxygen. That is a reason for lactic acidosis. So this drug, will it help? After starting this drug, what happened to the acidosis? It improved?
I think.
Definitely.
Probably because of dialysis, it would have improved. Yeah.
This dobutamine ideal condition is when the patient is having hypotension and lactic acidosis, it will definitely help. If somebody is having good volume, perfusion is good, due to some reason lactic acidosis is developing, then theoretically it should not work. Okay.
Then in the after the dialysis, the patient's the metabolic parameters actually improved. So the pH improved to 7.2, but he was still in anuria. So he required actually 2 to 3 more dialysis.
Okay.
Then we were managing we were managing him with the fluid restrictive therapies. So we were monitoring the input output also. So he was anuric for the first 2 days, first 3-4 days. So he was kept like that, and we have started him on corticosteroids also.
What is the indication of corticosteroid here?
In viral pneumonias and ARDS, corticosteroids can be given, sir.
Can be tried.
Can be tried, but there are also side effects that if in
immunocompromised, especially in COVID-19.
That there is a high risk of immunocompromised states can come, and it can cause fungal infections can come.
Okay, mucormycosis is very common in patients who received high dose of corticosteroids.
And another thing is that prolonged viral shedding is also being reported with people on higher steroids.
Then
what is the incidence of critical illness neuropathy in steroid use? In patients who are getting continuous steroids due to any reason, like you told viral pneumonia, we can try. But continuously if we give steroids, what happens to them? It can induce critical illness neuropathy, and same time it is the treatment also. Okay, so it is very difficult to treat this critical illness neuropathy. If possible, try to avoid. Initially you can give, but continuously don't try to give steroids in any patients who is having pneumonia.
The evidence is not very strong for steroids. Okay.
Initially we can try, like H1N1 and all, it gives good response, but COVID response is good, but the complications are more.
Then DVT prophylaxis was given, sir, and with heparin, and stress ulcer prophylaxis was also given, sir. Actually his oxygenation improved with these management, sir. If at all his oxygenation was not improving, then we will have to plan on other measures, sir. So open lung ventilation and recruitment manuals are not ideally used nowadays, sir. It is not recommended now, sir. So we can plan on a prone ventilation for this patient.
Okay. Initially itself, not late.
Initial proning itself. So if at all we are planning for proning,
how do proning improves the ventilation?
Proning, the posterior part of the lungs is actually more, sir. So that will help in recruiting more of the lung surface area will be more recruited, sir.
What are
And
the
it will,
contraindication for Pruning? Any contraindication?
yes, sir. It is contraindicated in case of post-spinal surgeries and rheumatoid arthritis and all, and if the patient is on multiple supports.
Rheumatoid arthritis, why it is contraindicated?
And arthritis, like spine problems.
It is not a contraindication. Facial injuries?
Facial injuries are there, pregnancy,
Pregnancy.
chest burns, or if the patient is having any chest drains and all.
Unstable patients.
Prone ventilation, prolonged proning can be done, sir. That means for more than 17 hours, proning can be done, and that can actually increase the recruitment of the lung and can reduce the FiO2 requirements, sir.
Suppose you are proning the patient for like now we have, there are some studies to prone the patients for 36 hours and all initial stretch itself. You do a first proning and then reverse the patient, and patient again desaturates. What will be the next step? There is
Again we can prone.
There is reasonable evidence to suggest that one more session of proning can be given. Okay.
Then complications are there can be pressure sores, then exposure keratitis, injuries and all can be there, sir. And there is a high risk for ET tube displacement and all can be there. Then other measures are we already told recruitment manuals are not used now. Then if the PO2 FiO2
if at all you are using recruitment, it's not like you cannot use, but there will be situations where you can attempt for early recruitment. What is driving pressure?
Driving pressure is actually P plateau minus PEEP, sir. So ideally it should be less than 15.
Well, yeah. With the guidance of driving pressure, you can try to see what is the optimal PEEP. Okay.
Then in recruitment also we can recruit in two ways, either by gradually increasing the PEEP or by keeping a PEEP as between 30 to 40 for 40 seconds and recruiting, and then after that keeping the PEEP low. There are side effects like it can cause hemodynamic instability, hypotension and all, and there is a risk for barotrauma also.
What happened to this patient afterwards?
This patient actually improved. We never want to prone this patient after dialysis and after ventilator management. This patient improved.
What will be your final diagnosis? Anything came positive? Infectious parameters?
No, sir. All the blood cultures, BAL, everything was sterile only.
Okay, no viral markers like H1N1, COVID. Nothing is positive.
No.
Leptospira?
No, it was negative, sir.
Renal failure, did it reverse?
Yes, sir.
Completely reversed.
Yes, sir. At the time of admission, his creat was 8. Today, his creat was 2.9.
Of dialysis.
Of dialysis, and he is producing good urine output also.
So, tell about antibiotic adjustment in this patient. We started meropenem. We don't know what was the infection, so we started meropenem and azithromycin. According to renal clearance, how did you adjust the dose?
Yes, sir. So initially,
so I want to start meropenem. This patient's creatinine is 8. Okay, I want to start due to various reasons, maybe infectious, thinking about infection or hospital acquired infection. Whatever it is, I am starting meropenem. How do you start it?
We will have to initially we can give the full dose as stat dose, sir, and after that we will have to measure, look for the creatinine clearance, and depending on that we have to adjust the dose. Okay. And if that all the patient is getting dialysis, we can adjust accordingly also.
Okay, we can time the drug. So how much meropenem was given for this patient?
Initially 500 once a day, sir.
Okay.
Then after that we were able to give 500 twice a day. Today the creatinine clearance improved to 35, so that we can give meropenem 1 gram BD.
So suppose we don't see creatinine clearance, we give high dose. What would happen for this patient? Why we are worried? Why we are worried? Renal failure. What are the side effects of high dose of meropenem? That you should think. What are the adverse effects of high dose of meropenem?
Seizures.
Seizure is the most important thing. So when you are giving very high dose, supratherapeutic doses, this patient can develop seizure, but that is only theoretical aspect. Some experts say that even if the patient is having renal failure, In a severe infection, you can give full dose. Because what is the dose of meropenem in meningitis?
2 grams
Just
thrice.
2 grams 3 times. Okay, so that much high therapeutic dose can be given for meropenem, but some patients can develop seizures. So in an infection which is producing renal failure, you can give higher doses. Okay, not that you have to always go according to the creatinine clearance. Some 1 or 2 days you can continue the full dose, then you can step down. Okay, that is also possible. Okay, but for the safer side, we always try to keep it in creatinine clearance and give the dose.
How did you extubate this patient?
This patient actually, we can start spontaneous breathing trial once the PEEP is less than 5 and FiO2 requirement is less than 50%.
PEEP of 5 or 8?
8. We were able to bring down the PEEP and we gave him a spontaneous breathing trial. So initially he had some difficulties, but after that he was able to we were able to tolerate these things. So we stepped down into a SIMV mode, and after that we were able to extubate.
From SIMV directly or pressure support trial you gave?
SIMV pressure support, with pressure support.
Okay. And you extubated to room air or you extubated to NIV?
He was extubated to NIV, sir. Extubated to NIV, and initially we continued on NIV with the pressures of 12 and PEEP of 6. We were able to maintain there, and after that now we are weaning, and he requires only NIV for 2 hours. 2 hours NIV and 2 hours break.
Okay. Discharge. This patient is
discharged? No, sir. He's still
there. Okay. But we don't have a clear-cut diagnosis why this patient developed this problem. Okay. Can you tell? Do you want to investigate further once the patient settles down? Want to investigate this patient for something else? This is a pulmonary renal syndrome. We didn't get any infectious cause for that. We had given steroids. So what other possibilities you will suspect, and you may ask for further investigation once the patient is fully stabilized. Vasculitis should be ruled out. Like where lungs are involved, kidneys are involved. We don't know what is the reason. We had given steroids, patient has completely improved. We don't know whether it is due to steroid or antibiotic. So we have to wait, and if the patient develops any other problem, you may have to investigate in that line. Okay.